Good evening, everybody. Welcome back. Another episode of Mondays with Moshe. This is Moshe Norman from Lakewood, New Jersey. Tonight, we are honored to have the presence of Dr. Colin Ross out of Texas, where the weather is probably a whole lot warmer than it is here. Is it? Okay, well, one reason to
80 tomorrow.
80 degrees tomorrow. It's no wonder that you moved from Canada to Texas. That's the place to be.
No doubt.
Yeah. Okay. Well, Dr. Ross is a great contributor to the field of psychotherapy. He's actually a psychiatrist and one of those rare unicorns that's still around, who actually practices psychiatry and psychotherapy, which is a great breath of fresh air when we meet somebody who actually takes the entire picture into account and doesn't just prescribe and send the patient or client on their way, but actually prescribes if need be and treats, which is really, really wonderful. So thank you for that. That in itself is a great contribution to the field. But besides that, I mean, we're talking about an author of 36 books and almost 300 articles, peer-reviewed articles.
Correct.
So, okay, so that's pretty incredible. So Dr. Ross, I know somehow you fell into the world of schizophrenia, psychosis, and dissociative identity disorder, DID, which probably wasn't called DID for most of your career. You probably still stumble saying DID.
I kind of got used to it now.
You gotten used to it by now? Okay, so can you tell us, first of all, thank you for agreeing to be featured. It's a real honor to have you here, and I hope we'll have a really exciting night together. But tell us, who you are, how you fell into this specialty, so to say, and how you became so fascinated with it that you've contributed that much.
Sure. So born in Canada, grew up in Canada, went to medical school, did my psychiatry training in Canada, academic hospital-based psychiatrist for 6 years. And then in 1991, I moved from Winnipeg, which is kind of dead center in Canada, to Texas, where I've been ever since. So verified by my mother, because I asked her a number of times, I decided to become a psychiatrist when I was 9 years old and started talking about that and consistently kept that going.
Now that information was verified by your mother, but I hope it was also explored as to why you decided to become a psychiatrist at 9. And what contribution your mother had to that decision?
Well, all I remember about the decision is I'm watching a TV program, and it's black and white back then. There's a man standing in one of those easels where you flip the paper over, and there's a diagram with a side view of the head with a line. Above the line is the conscious mind, and below is the unconscious mind. And somehow I just went, now that's interesting. And that's what caught my attention. Then in Canada, it's called grade 4, 5, 6, not 4th, 5th, 6th grade.
Right.
So in grade 4, 5, 6, I was in what was called major work, which was sort of an experimental enrichment program, where we had the same classmates and the same teacher for 3 years. And every week, 2 or 3 classmates would give a talk on whatever subject they wanted. So over the course of 3 years, that's a lot of talks, right? Yeah. And I gave talks on a whole variety of subjects, including Canadian doctors, famous doctors, mental health stuff. And so it's just pure intellectual interest that got me into it.
Well, so you're really talking about 10, 11 years old, being interested in psychiatry and the human mind.
Yeah, and medicine and science and a whole variety of topics. So the provincial park where we had a cabin, I gave a talk on that and the geology and the history. Remember one on how radios work, one on bees, one on Bridie Murphy. Bridie Murphy, this was a book in the 50s. So she was a woman, and it's biography about her. This is a woman who remembered a past life in Ireland. And so that was amazing. She knew all these details about this little town in Ireland. And lo and behold, after it was thoroughly investigated, she had a nanny at age 1, 2, 3 who was Irish, who told her all kinds of stories about Ireland. And that's where it came from.
Hmm.
I thought, well, that's interesting too. So did a talk about that. So
So it sounds like you had a variety of interests, or
yeah,
you were just interested and
yeah,
curious.
interested in life. Yeah.
Well, that's the hallmark of being a good psychotherapist, isn't it?
You better be interested in life. Yeah. I don't understand how people are not fascinated by life. It's so rich and complex and interesting and puzzling and awe-inspiring and tragic and comic all rolled in one.
Mhm.
So flash forward to I'm now in third year medical school doing my 8-week psychiatry rotation, knowing I wanted to go into psychiatry, but being careful not to mention it to too many people because the surgeons and the internists were not impressed. And a couple of weeks into the rotation, I'm assigned somebody to do a history on, and she ends up telling the story of a week prior to being admitted. She came to, this is in Edmonton where I went to medical school. She came to at the airport and she had amnesia for the week before that and didn't know where she'd been. And then going back for a month before that, she had normal memory, but she also, for the first time, so now we're like 6 weeks ago, she came to at the airport and there was a whole month missing. So it was a case of amnesia and there was nothing with her brain, etc. So that was interesting. So I took the history and I had read a little bit about hypnosis. So I was practicing hypnosis on the patients, the inpatients, for anxiety reduction and helping to go to sleep and stuff. It's helpful to them and good practice for me. So then she had told me, oh, my boyfriend, who's kind of a wealthy construction guy, I got some money from him somehow, and I opened all these bank accounts. Hold on, that's not the right sequence. So she tells me that there's this missing time, and she doesn't know where she was and how she spent the money. So I decided to use hypnosis. So I hypnotize her. Do you know how you paid for that? And turns out she sort of borrowed money from her boyfriend and put it in 4 different bank accounts. And then she went and got all the information about those bank accounts, and they did exist, and the money was all drained down to zero, and the amount deposited was such and such. And what she had done was gone back to Eastern Ontario, where her husband, from whom she was separated, and her kids were, and bought them a whole bunch of presents and stayed down there and visited them. I thought, wow, this hypnosis really works. And then one time, just in the course of a conversation, she said, sometimes I play this little joke on my boyfriend. And I say, well, that was not me who kissed you. That was Susie. And I went, yeah, what? Okay. And then I can't remember why. Next time I'm putting her in hypnosis for trying to figure out all these memories, instead of going, say her name's Mary, instead of going, well, how are you feeling now, Mary? I'd say, how are you feeling now, Susie? And 11-year-old Susie's, hi, Dr. Ross, I'm good. So, what? Case of multiple personality disorder. And then actually my supervisor was away on vacation, so I had to wait till he came back, and I talked to him. There's another supervisor filling in, but I didn't really talk to him much. He says, oh, I've got this case of multiple personality. Who should I talk to about that? He goes, no, I don't know. Okay, well, what should I read about it? I don't know. Try going to the library. This is the supervision I got, because nobody knew anything. So I ended up getting some of the literature together, which was tiny. And it turned out that this was case number 201 in the world literature.
Wow.
So, okay, well, what are the odds statistically that I bumped into case number 201 if it's really all that rare? So right away, here's the puzzle. Is it really that rare? And this is an incredible fluke, or is it actually quite common? And for some reason, I'm just open to picking up on it.
Mhm.
Or am I one of these nutcase psychiatrists who sees it everywhere when it doesn't really exist? I'll leave you-
or wait, through hypnosis, you may have created it.
yeah, that's what the people would say. And funnily enough, I published 5 years later, I published the case history in a hypnosis journal where the editor is one of the big skeptics saying that it's all an artifact of hypnosis, but he accepted my paper. So that's how I kind of stumbled into it. And then I thought, okay, well, once in a lifetime, never see that again.
Mhm.
And then when I'm a first year resident, I bump into another case, work with that person in therapy a bit. And then now we're 1985, 2 or 3 months after finishing my residency training, diagnosed another case. And so now I'm the leading expert in Western Canada with the most experience. I started doing some talks and doing some writing, and then a whole bunch of cases get referred to me, and then the tsunami hit and I never got out from under it.
Mhm.
That's how I got into it.
So this is really your hitting on gold. You hit on multiple personality disorder, as it was referred to at the time,
Right.
and you kind of discovered what it looks like, and then you're able to start identifying when you're seeing it. And,
Exactly.
you're kind of setting me up for the next question, which is how many of us are treating people who might have multiple personalities or dissociative identity disorder, and it's glaring and staring us in the face, yet we just don't know what it is, so we don't know how to identify it.
Lots
How
and
likely
lots
is
and
that?
lots.
You think lots?
Oh, I don't just think lots, I know lots. So
So-
how do I know that? So the sort of folklore that dominates the field is it's very rare and highly questionable. So I just actually sent a revisions to a paper back to a journal because I had to make some changes because reviewers wanted some changes. And in that paper, there's discussion of a paper by another person who reviewed 98 studies of college students where they were assessed for dissociation. So that's 98 studies. That's a big literature. And overall, it comes out about 15, 16% some type of dissociative disorder, and about 3% multiple personality disorder, dissociative identity disorder.
Mhm.
And then next paragraph, I cited my own paper, inpatient studies, and there's 6 different languages, I think, and 10 or 12 studies. Inpatients that we assess with standardized interviews. They've never had the diagnosis before. They don't think they have it. Nobody told them they have it. They're not claiming to have it. Again, about 15% of inpatients and about 3% inpatients with dissociative disorder, 3%, 4% with DID. So there's replicated international literature showing that these things are not rare at all.
So we know that if we're treating 100 patients, we're going to have 2 or 3 that are struggling with DID. Is that what you're saying?
Inpatients. It can be a little more frequent in inpatients.
Okay.
General population, there's 3 studies, one of which is me in Canada. It's more like 1% of the general population,
1%.
which includes a lot milder cases than you would see on the inpatient setting,
Okay.
which is true of any
Because
disorder.
then they'd be inpatient.
Yeah.
Got it. So for those of you just joining, we're on with Dr. Colin Ross on Mondays with Moshe. It's now 9:15 here on the East Coast. And if you can, please turn on your videos. Of course, it's always much nicer and much more personal when we have some faces. So for those of you who can turn it on, it's greatly appreciated. And for those of you who have questions or comments, please click the reactions tab on the bottom right of your screen and we'll call on you. Okay, so we're talking about dissociative identity disorder, also known as multiple personality disorder. Thank you, Tiki and Diane, for turning on your videos. Nice to see you again. Dr. Ross, can we start with just a very basic question? Maybe it's not a basic answer, but what are some of the telltale signs? I mean, we're treating people. Sometimes our clients do things that are strange, that are different, that are unique, than the typical person who's just coming in and talking things through. And sometimes when they do those strange things, we wonder what they are. How do we start to question whether there's a multiple person, another alternative personality that's coming into the room? when should we be looking for that?
All the time. No. So I just explained this today actually to somebody. So I call it the dissociative spectrum. So at the left-hand end of the spectrum, we're talking about the inner child. The inner child is just a metaphor. It's a figure of speech. It just means unresolved feelings from childhood. And people, therapists talk about your inner child. At the right-hand end of the spectrum is DID, MPD, multiple personality, where the inner child is not just a metaphor, comes out, talks to you, different name, different age, different memories, different way of speaking. And then the inner child goes back inside and the adult doesn't remember the conversation. So that's more than just a metaphor. And then there's all degrees in between. So one person says, oh, no, don't have an inner child. Next person is, I know what you mean. Not really, but yeah. The next person is, yeah, I can kind of feel a child in there. And the next person is, yeah, I even can visualize her internally. She's 7, she's hiding in the corner, she's crying. And then I'll ask a person, where do you think you are on that spectrum? So we're now talking about 3/4 plus of the way out the spectrum. So if you're all the way out, it's full DID. If you're kind of 3/4-ish, which is partial DID, that used to be called in DSM-3 in 1980, it was called atypical dissociative disorder. DSM-4, 1994, it was dissociative disorder not otherwise specified. Now in DSM-5, 2013, it's other specified dissociative disorder, because psychiatrists are just like to change jargon. But it's all basically DID 3/4 as much. So in order to pick up somebody who's out there 3/4 plus, there's a set of questions that are in a structured interview I developed, other standardized interviews and so on, which most mental health professionals are not trained, not taught, don't ask. So there's no mystery to why it's not picked up. It's just like, if you don't ask about chest pain.
Okay, but Colin, in all fairness, I mean, we can spend 6 months doing interviews on clients or patients. We're only going to do an interview, presumably, on somebody if we get the sense that there may be, we're not going to do a suicidality interview on somebody who looks happy. Presumably, we're going to do a DID interview on somebody who we suspect has some dissociative qualities. Is that right?
Yes and no. So if you're doing an intake interview, especially if you're in the emergency room or inpatient setting or residential treatment center, you're going to be thinking, how much anxiety, how much depression, how much substance abuse, is there an eating disorder, panic disorder? You're going to just be asking about all that stuff. Mm-hmm. So dissociation should just be on the list of stuff that you're asking about. But the things that cue you in are big trauma history, complex physical, sexual abuse, family violence, loss of caretakers, neglect. So most people with DID have pretty severe chronic childhood trauma. So as soon as you have the big trauma history, doesn't have to be DID, but now I'm thinking about it more. Mm-hmm. And then voices, auditory hallucinations. And then you want to ask about periods of missing time. So if you have the big trauma, you got, yes, depression, yes, anxiety, yes, PTSD. Already you've got lots of comorbidity. Mm-hmm. So it's complex PTSD kind of picture already. Mm-hmm. Then the question is, okay, how much dissociation is there? There's bound to be a bunch. And so it's the big trauma history, lots of comorbidity, auditory hallucinations, and then I'll get back to those in a second, and then memory trouble. So to ask about the memory trouble, you start, as always, with an open-ended question. Any trouble with your memory? Mm-hmm. No, memory's fine. Okay. Yes, I have a terrible memory. Okay, tell me a little bit more about that. And then what you're looking for as you narrow the questions down is not just, I forgot where I put my pen yesterday.
So it's more like lapses.
Yeah, so it's discrete chunks of missing time. Mm-hmm. No drugs, no alcohol, no head injury, no seizure.
So interesting. What I'm hearing you say is you're going to start digging when you hear a history, a significant trauma history.
Yeah.
So without even necessarily sensing or seeing telltale signs of anything, you're going to start. Right. You're going to start assessing.
Exactly.
So that's different than the question I was asking. I was looking at it more if I get the sense, and I could tell you a case in point, where a client will start speaking in a different kind of voice, in a pipsqueaky, childish voice. What I was kind of thinking about is, do I start to think that this is DID, or am I thinking this is the person just expressing their inner child? They're regressing in the therapy, but not necessarily dissociating. How would I differentiate?
Well, that's a matter of definition. If they regress to a child and they're acting and behaving like a child, they're behaviorally dissociated from their normal adult behavior.
Mm-hmm.
So that's already dissociation in and of itself, even though it's not DID necessarily.
Because it's not the ID, because they're present. My question is, if they know, if I can now process with them and say, I notice that you're speaking like a child now.
Mhm.
And they can say to me, well, I'm speaking like a child because I'm feeling very vulnerable, or I'm feeling very little right now, or I'm feeling like I need my mommy right now.
Right.
Doesn't that mean that they're not in a dissociative state? I mean, they may be somewhat dissociating, but they're also present.
Well, so remember, it's all on a spectrum. So they're in a somewhat dissociated state, but not a fully dissociated state. Because they're not in their normal adult self, right?
Yes.
So that's obviously like a big clue. You got to look into this more. But if they say just exactly what you said, there's no amnesia, they can pull themselves out of it consciously, they know what's going on, they realize it was just temporary. That doesn't sound like DID. But the person with DID, they'll have these discrete blank spells. Usually, currently, recently. Sometimes there can be a period in life where it all kind of went quiet. So they weren't in a lot of stress, life was going okay. Maybe they just got married. But then when you go back in time from there, usually in childhood, adolescence, early adulthood, and then variably all the way up to the present, chunks of time, like not just a minute, not driving the car and you miss your exit. It's many minutes, hours, sometimes even days or longer. Lights out, lights back on. So most people just don't have that experience. And in the absence of some oddball seizure disorder. And then you want to know, okay, how often do those happen? How long are they? Anything that triggers them off? When did they start? And then it just kind of follows automatically. If you think, okay, it's like there's other people inside who aren't actually other people. They take control of the body, they do stuff, and the out front person doesn't remember. Then everything kind of follows logically. Okay, so do you ever have one of those blank spells and you come out of the blank spell and you're somewhere else and you don't know how you got there?
Well,
do people ever tell you about stuff that you've done that you don't remember? Do they describe how you behave? You get a description. And sometimes I act like a little scared kid. Sometimes I'm angry and throwing stuff. Sometimes I'm the life of the party and all extroverted. And who tells you that and how often? And well, my husband, my partner, my best friend, my friends told me that in high school. Do people ever come up and talk to you and they know you and they maybe even call you by a different name and they talk about stuff you've done recently, but you have no memory? How often does that happen? Do you ever find samples of handwriting that are yours in a journal and you don't remember doing that writing at all? What's the writing about? Does the script look like your regular handwriting, or is there like block printing or angry printing, and what's it being in the writing that you didn't do that's different handwriting? What's it about? Is there ever somebody in the journal talking about you or talking to you or commenting on you? So that's just not part of regular questions that people ask, right? And the more of that you get, then it's the voices. Okay, do you hear voices talking in you that other people can't hear? When do they start? How often? How much recently? But tell me about the voices a bit. And then they'll tell you a bit. Do any of the voices have any kind of specific age? Sometimes they'll be, no, not really. Sometimes, yeah, there's one voice that's 27, one that's 16, and one that's 9. to the voice.
Why is that a significant characteristic?
Sorry, what?
What is significant about the age of the voices? In other words, is there something telling about that signifies that it's DID versus schizophrenia or other psychoses?
Well, that's going to lead us into the overlap and difference between schizophrenia and DID. But just sticking with DID for a second, like people with depression don't say, even if there's some psychotic features, they don't generally say, you know, I have a 6-year-old little girl, I have a 13-year-old girl, I've got a 17-year-old angry guy, and I've got, you know, somebody who sounds like my mother telling me I'm no good. It's not that kind of rich detail. And do the voices talk to each other? Do they talk to you? Do they comment on you? So just this rich history of what's going on with all these voices. How do they behave? How do they act? And a fair percentage of people at the time of initial diagnosis will tell you that they feel like there's other people inside them who come out, take control of their behavior and do stuff. And then there's going to be some people who are like, no idea what's going on. I just thought I'm crazy, or I just thought everybody's like this.
So people with DID, do they actually remember their other states? Because I was under the impression that they don't remember their other states at all. If they're hearing voices, does that mean that they're connecting with other parts of them, other personalities?
Right, because if they, so it's all variable. So some people know nothing about the other parts of themselves. All they know is they hear these voices and they have chunks of missing time. And sometimes they think everybody's like that. But quite often they know a lot of detail and they just haven't quite put it together as DID. Or some people go, yeah, I always thought it was multiple personality, I just wasn't sure. So
they're really almost conscious of their multiple personalities, quite conscious.
Well, so the stereotype of people who think it's stupid and ridiculous, the stereotype is there's no symptoms of any kind whatsoever. And you come in and talk to Dr. Ross, and all of a sudden you've got all these people.
Yeah, that's how the movies portray it.
Right, but that's not actually the case. There's a history of all these symptoms going back in time, and sometimes verified by outside friends, neighbors, family members, etc. So there's partial awareness of what's going on to different degrees, but knowing nothing at all about it is very unusual. And total amnesia for the childhood trauma is at most like 2 or 3% of cases. So it's not that the trauma is totally blocked out and they know nothing, which is a stereotype. It's that various bits and pieces are blocked out to different degrees. Maybe, you know, stepdad lived in the home from 9 to 11. I don't remember anything from that time period. Did you find out what was going on?
You say stepdad, and I think of Trudy Chase, who had 92 personality. I think they identified 92 personalities, was it?
I forget the exact number, but it was a bunch. So that's another issue. I'm on 4 or 5 papers about maladaptive daydreaming, which is not in the official books yet. But I and the co-authors and so on have developed a self-report measure, proposed diagnostic criteria, a structured interview. We've got statistics on it and so on. And there's quite a large international online community about this, and there's multiple research groups now and 30 plus publications. So it's a growing field. And it's basically not DID. It's people who have many, many, many hours per day absorbed in a big, complex fantasy world with characters and plots. They know it's not real. It's their imagination, and they can enter and exit that world. Except it's got this kind of compulsive addictive quality, so sometimes they lose a bit of control. And it's maladaptive because it generates anxiety and distress, and you can't function when you're in a daydream world all day.
And at the same time, it's adaptive because it's a coping mechanism for high distress, dissociation that they need in order to soothe themselves.
But it's just like any coping strategy, like, you know, having a drink to relax in the evening is fine, but when you're having a drink 16 times a day, it becomes maladaptive.
Correct.
So, which is true of everything in the mental health field. So the idea being here that I think there's an really interesting, underthought about, understudied overlap between maladaptive daydreaming and DID. So some people have maladaptive daydreaming, no DID. Some people have DID, no maladaptive daydreaming, but there's a subgroup, which would Trudy Chase would be a candidate, except she's not alive anymore, where there's like way too many alters. There's like 92 or 172 or some huge number. So I think that those are not the type of alter personalities that we see where there's 4, 5, 6 of them who've been out like months or total of years in their life. You can't have 500 personalities have all been out for 6 months, right? So I think that's kind of a more of an internal world with characters. And the person calls them alter personalities, thinks of them as alter personalities, but they're not actually. It's a different process. Overlapping with more fully formed DID characters.
So would you say that, I guess somebody who needs to dissociate somewhat would go into maladaptive daydreaming, but if the distress is too intense, then they would go into an alternate personality? Would that make sense?
Plus there's like anything, what's your inborn temperament? How good are you at doing that? Just like math or athletic skill or anything. Some people just have the ability to dissociate more. And then if you don't hit them with a whole ton of trauma, it's just a skill. Hit them with a ton of trauma, then they start going out that spectrum towards DID. Whereas another person who's very low on hypnotizability, dissociative capacity, you can abuse them a lot and they won't develop DID.
Okay, so let's talk a little bit more about the dissociative qualities in DID or variables, and then maybe we can jump into some treatment. But again, I do want to remind all of you, if you can turn on your videos, that would be great. If you can raise your hand if you have a question, just use the reactions tab on the bottom right of the screen, and we'll be happy to take the question. Question for you. Let's first look at what is the mechanism of an alternative personality, in particular, a specific alternative personality. So I'm going into, like you said earlier, 7 years old. I'm now a 7-year-old little boy. How is that like a kind of reset to prior to the abuse? Why would I create multiple personalities and not sort of one macho personality that will just carry me through any potential trauma, or something like that? Why do people create a personality of a 7-year-old, of a 12-year-old, of a 27-year-old, etc.?
Well, the first answer is I don't know, just because they do.
Okay.
When you get the basic, if you ask, what's the basic mechanism of anxiety? Nobody really knows, right? Brain-wise or psychology-wise, like how does your brain actually create anxiety? Well, we know a little bit about the biology of the brain, but from a psychological perspective, we give things names like extinction. Extinction is a psychological process. Whereas if you do prolonged exposure and you think about it, you imagine it, you relive it, extinction kicks in and the anxiety goes down just from the exposure. Okay, so we talk as if that's a mechanism, extinction, but really we're just describing what happens and calling it extinction. We don't really know exactly how that operates or works. So in general, we don't really know mechanisms. So it's, I think, back to your dissociative capacity, how severe is the trauma, and how good is your mind at creating parts, and then what's the need for this part, this part, and this part. So there'll be often several parts that hold different traumas at different ages. So that's a trauma container part. There can be the tough macho male who comes out and gets angry.
That was the next question I was going to ask, is why would a female create a male part?
Well, because cultural stereotypes that guys are tough and strong and kick
so this will somehow be a protector for her.
Yeah. Or it can be, well, it's a false belief, but boys don't get abused. I got abused because I was a girl, so I'm going to have a boy in there. So
okay, that makes even more sense to me.
Or I can have somebody old and wise who's like this good grandmother who could be some transcendent spirit, or could just be an unnamed part, or could be
someone supportive. It could be a supportive part, somebody who's holding and supporting.
Yeah. So those are called persecutor parts and protector parts. And then there can be all kinds of combinations of genders and sexual orientations. So if you were a girl who's sexually abused by males, which is the most common, I actually just reviewed a paper that was talking about a data set based at Cornell University, which is all the Child Protective Services sexual abuse cases nationally are all archived together. And lo and behold, as we know, 90% of childhood sexual abuse perpetrators are male. Girls are sexually abused more often than boys. But I didn't know before, there's a couple of states have high rates comparatively of female perpetrators. Puerto Rico and Hawaii, and then for some reason, Arkansas and North Carolina. And then Montana has like 1% female offenders, whereas those high states were more like 30%. And in group home settings, 30% of the perpetrators are female. So, but
Meaning across the board? You mean in all states?
In group homes, yeah, across the board, yeah. So, but by and large, it's 90+% male perpetrators. Many more girls abused sexually by males than boys abused by males, just because most males are heterosexual, right? And then there's pedophiles are just opportunities. They don't care anybody they can get their hands on. But if you're a girl and you're sexually abused by dad, uncle, neighbor, then you're going to, by just normal childhood thinking, you're going to have self-blame. It's my fault. I brought it on. I'm the seductress. And then we get to, well, then I'll have a boy because boys don't get sexually abused. But then you're going to naturally become uncomfortable about being sexually involved with males. So then you can create a heterosexual male alter personality and be sexually active with women. Or you could create a female lesbian personality who has sex with women. So then when you start thinking about it, there's all these different combinations that come up. And it's not really defending against the trauma as such, it's defending against conflict that arises from the trauma.
Interesting.
And then there's just no end to all the variations on theme.
So in other words, I imagine that the job of the therapist, and now, if we could start moving into treatment a little bit, the role of the therapist, would that be to begin identifying the values of the various personalities, or are we going to work with, what does the treatment look like for DID? Let me not pretend that I know.
It looks different in different hands, of course. And like everything, there's different opinions, etc. But it's all your basic therapy. So I always say, it doesn't matter if you're talking about cognitive therapy or this therapy or that therapy. At least half of the power of the therapy is completely non-specific. It's your basic Rogerian principles, good treatment alliance.
What they call the relationship.
The relationship.
Good of the relationship.
If you don't have that, forget it. So you want to build a treatment alliance. And this is the 3 phases of trauma therapy in general for PTSD. You've got the establish safety, establish a good working relationship, set your treatment goals, basic stabilization and containment. So you don't want to be exploring the intricacies of the personality system when the person's getting beaten by their husband every night, right? You got to address that. And you got to get some grounding, self-soothing skills, some basic coping strategies, maybe get the substance use or the sexual promiscuity down a bit, and then start doing the trauma processing, whether it's PTSD or DID. And then the 3rd phase is more the resolution consolidation phase, which applies to DID. So before you do anything specific, you better have all those good general principles in place. You better have good boundaries and good ethics yourself as a therapist. And then it's, the pace varies from person to person. So I'm a big pro EMDR guy, but when I'm making the point, I'll go, oh, there's a therapist, EMDR therapist. Here's how she practices. Hi, nice to meet you. Follow my finger. Right. And so that's making the point that we see people where the EMDR therapist dove in way too hard, way too fast on trauma memory processing. And the person just got completely flooded and melted.
Yeah.
So we got to make sure we don't dive in too hard, too fast. And the pace that the person can tolerate varies a lot. But then you want to do some basic mapping of the system, like who's there inside, what do you know about them, what are their roles, and who's involved in the current problems. So you've been cutting on yourself during blank spells. You've been hearing voices telling you to kill yourself. You've been acting out sexually and without good protection, and you don't really want to do it, but parts are going out and doing that. So who is it who's involved in that? So you kind of get the lay of the land. And then
When you say who, you mean which parts?
which parts, yeah.
Mhm.
And then you just teach what DID is and what it isn't. It's not insanity. It's not literally separate people. It's all part of one person, but it sure feels like it's separate people.
Psychoeducation.
Yeah, a bunch of psychoeducation, just like you do in all therapies. And then it's, if there's parts who already are writing in the journal, it's called switching when another part comes out, already switching in life, then you can ask if you can talk to them. So there's a talking through technique. So, hi, so Moshe, you've got this voice telling you that you're no good and you should kill yourself. So something we do sometimes is we just ask the voice a question. The voice answers in your side of your head and you tell me what the answer is. Would it be okay to give that a try? You say yes. I say, okay, so angry voice that's telling Moshe to kill himself. Anything that you want to tell me, ask me. I'm just mainly wondering if you're there and you're listening. And then there'll be kind of a little pause, and it could be nope, nothing, or could be a whole bunch of swearing that the person doesn't want to repeat, or it could be, what do you want? Or it could be, you're not going to get rid of me. I'll explain the goal of therapy is not getting rid of parts. We couldn't even get rid of parts if we wanted to, so we'd be wasting our time and energy. And you're all there for a reason. You're all part of the whole person. This is about building a team inside and getting you more involved in treatment, not getting rid of you. And I don't expect you, angry voice, to believe that just because I'm saying it. But so keep an eye on things and, make sure you hold me to that. It's not just a fake promise. So yet again, anything that you want to tell me or ask me, and then you may get something or you may not, but it's just like interviewing an angry teenager. If the teenager says, I hate you, I'm not going to tell you anything, I go, good, we started a conversation.
That's right.
And so it's kind of like slowly reeling the parts in.
And Moshe will be able to access his angry part just because Colin asked him to?
Well, it's a skill that takes a little time, right? So then.
And will anything stop Moshe's angry part from now predominating and taking over Moshe and coming to the session? Moshe losing himself?
Well, that's already been happening some, because the part's been coming out and breaking things and acting out, as confirmed by the husband who says, in your, I was going to say she, but in your case, yeah, it's sometimes he's like a totally different person. I don't know what's been going on. And then we have a conversation, and then 5 minutes later he says, well, I never said that. We never talked about that. So the husband will, or the wife.
I guess I mean, will you activate, is there a risk that you'll activate the part of me and now that part will become present and myself will get lost and you'll be just addressing, in other words, I'll go into dissociative state?
There's a risk. Okay. All therapies have risk, right? Just like surgery, there's no risk-free surgery, but it's incredibly rare to talk to the voice and then the voice comes out and takes over for like a year nonstop. Because basically that's not the way it works. And the voice doesn't really want to be, dealing with breakfast and shopping and all this stuff anyway. So it just sort of automatically tends to be time limited. So the goal and the idea is to get these parts to be chaotically coming out and acting out less, with Moshe having co-consciousness, which is there watching at the time. And so if you do it reasonably skillfully and reasonably gingerly, usually things get better, not worse. But as in all therapies, there's this, it's got to get a little worse before it gets better.
Right. Now, when you say we want the parts to be interacting, or we want them to be part of the therapy,
Right.
so are we somehow going to integrate the parts with the self and have, let's just say, I'm just imagining, but have Moshe now speak with his parts? A part of me starts to come up because I'm feeling triggered.
Right.
So a younger part or a macho part of me starts coming up. So is part of the goal of treatment to have us somehow address each other, acknowledge that you're there, appreciate what you're doing for me, ask you what I need from you or what you need from me, and sort of work together so that I can stay as present as I can and also coexist with you?
Yeah, exactly. So that's the intermediate phase. And then as parts are sharing feelings, sharing memories, brainstorming together, working together, talking to each other, there's just sort of a gradual de-differentiation. And I know people who've de-differentiated all the way back into one person and stayed stably integrated. But there's also people who don't want to get integrated. They don't want to get rid of all their parts. They want to just have everybody get along and have a peaceful coexistence, which is fine. That's their choice. It entails the risk of, if something traumatic happens in the future, you may go back to dysfunctional chaos, internal civil war, DID. But whatever, you can jump back into therapy then if that happens.
Is there a risk that they won't have the coping mechanism to protect themselves? Is that what you mean? In other words, if that part becomes integrated somehow, or they make themselves vulnerable to being reflooded, the abuse.
I'm talking about future abuse, new trauma that happens in the future.
I see. Okay. Let's take a question from Michal. Michal, go ahead.
You were saying about needing stabilization before going into trauma treatment. There was actually research that I had read that there's like efficacy to just start trauma treatment without the stabilization. And I was curious to know if you knew anything about that and what your thoughts were.
So first of all, that's probably PTSD, not DID research, right?
Okay, different. Yeah, but it isn't it like, okay.
So then
Similar.
The PTSD literature is all the treatment outcome literature, the APA, American Psychological Association guidelines for treatment of PTSD. The evidence-based treatments are CBT and prolonged exposure, right? But what's the population that research is based on? It's by and large functioning outpatients who come to appointments, once a week for 6 or 8 or 12 weeks. They're not suicidal. They're not shooting up the university, and they're excluded if they're psychotic, homeless, actively suicidal. They can't be inpatients. So it's by nature much milder mental health trouble. It's more simple PTSD compared to complex PTSD, higher functioning, less severe childhood trauma. So, okay, so
it was actually it was showing that it was CPTSD. It was complex trauma.
Okay. So then the question becomes how complex,
right?
And how much. It's all has to do with the sampling. What's the sample, right? If it's like inpatient level, total crisis, DID, you can't just dive in with trauma treatment. You'll just get flooding and deterioration. If it's somebody who's okay, it's complex PTSD, but they don't have massive ongoing trauma, they've got good social supports, they're pretty high functioning, they've got everything partially contained. Okay, now maybe we can dive in more aggressively. And we don't need the stabilization because they're already stabilized. So I'm skeptical about somebody who's got fairly high level of ongoing stress, lousy social supports, several addictions. You just dive into the trauma without any stabilization. I'm pretty skeptical about that, but you never know. And if it was possible, that'd be great. The shorter and faster, the better. I don't know if that's just thoughts there. there's no definitive answer to that.
That makes sense. Thank you.
You're
Okay.
welcome. Anybody
Thank-
else?
Thanks for that question. If anybody else has a question, please raise your hand. So let's continue. Oh, I'm sorry, Leah. Can you unmute if you can turn on your video? That's great. If you can't, that's great too.
Hi, sure. 1 second. Okay. I am really excited that you're on because a question just came up with a client of mine, and hopefully you can answer it. I had to get off the call for about 5 minutes, so hopefully, I don't know if you mentioned this and I missed it. But I have a DID client, and she just came to me asking about medication and if she should be taking medication. And a big question that we had was, is the function of medication for a DID client just managing, like anxiety, depression, or is there medication that will assist in the actual reintegration for the client?
All very good questions to which there's no like replicated research literature, right? There's not a single controlled drug study of any kind in DID at all. So we're just going on clinical experience and what we think. So, but almost everybody in all of psychopharmacology, nobody claims there's a medication for dissociation as such. I mean, even dyed-in-the-wool psychopharmacologists will claim that. And by and large, it's like antidepressants for depression, anxiolytics, et cetera, mood stabilizers. The question being, so whichever mood stabilizer, can that stabilize the DID? And the answer is sort of, kind of, sometimes, but often not.
And
So
once
it can be helpful. And some people they're very helpful, which is true just in general. If you just do bipolar depression, schizophrenia, it's kind of a 1/3, 1/3, 1/3 rule. 1/3 of people get like basically no benefit whatsoever or minute. A third get kind of some benefit, but nothing definitive. And a third do noticeably a lot better, which is not dramatically better than the placebo response rate. So that also applies to DID. And I've met lots of people who've been on all kinds of different meds and nothing's helped. And I've met people where, yeah, it helps some, takes the edge off. And then if there's anybody who's been cured by meds, I would never make them anyway, right?
is there a benefit of antipsychotics in this type of situation, or that what would that do?
So Moshe and I were talking before about we're going to maybe get to psychosis, dissociation, schizophrenia. So we have this idea that antipsychotics are antipsychotics, and antidepressants are antidepressants, and they're somehow like diagnostically specific, and that's why they're called what they're called. But actually, it's all just marketing, and it's just what indication was it discovered for first. So when you go in the antipsychotic literature, whether it's whatever, this one or that one, there's generally like the PANS is a standardized scale, which is positive symptoms, negative symptoms, and then there's a general psychopathology scale. And what you see is negative symptoms don't respond much. The positive symptoms come down this much, but the general psychopathology comes down that much as well, or even more. So and this is the trials that got the FDA approval. So they really could be called anti-general psychopathologics as much as
Interesting.
psychotics. So you can't come to any diagnostic conclusion based on response, because if the person doesn't respond, there's a lot of people with psychosis who don't respond. If they do respond, there's people without psychosis who respond, because it's the non-specific kind of general, sedation, calming down, anxiolytic kind of effects. So with people with DID who are above the window of tolerance, if meds can kind of bring them down without like, just bring the hyperarousal down to a manageable level, then they can actually participate in life and therapy more effectively. But the effects are pretty non-specific. And then some people where like the voice is just like locked away inside, and then they'll go, great, the voices are gone. But then when they stop the medication, of course, the parts now are back up and online, and they're pretty pissed off and not happy about the situation.
Thank you so much. That was really helpful.
You're welcome.
Okay, so let's jump back and continue the discussion on treatment. You know, you had started saying that some of the basics, of course, are in order to get the treatment going.
Right.
Then you were talking about asking permission to access the different alters and speak with them. Kind of the sense I'm getting is creating safety for those alters so that they can all potentially coexist in the room of the therapy.
So there's a thing I call host resistance, the problem of host resistance, the host being the part who's out front, who isn't really the self. They're the part who's had the role of being out front and doing life. And that part is often don't want to hear about them, they're bad, want to get rid of them, which is totally understandable because they're holding all this pain and conflict. But it's not doing them any good, and they're not going away. So you're just compounding the situation. And how about if we have so your Moshe with DID, which I've got this plan of therapy. Tell me how you like this. We're going to get rid of you, and your angry adolescent part is going to take over and live the rest of your life for you. Do you like that?
No, I want to keep me. I for sure want to keep me.
Right. So how do you think they feel when you want to get rid of them? They're going to be totally against therapy, hate you, counterattack you. It's just not working. And basically you're stuck with these parts. And are you an angry guy? Do you get into fights all the time and cause lots of trouble? No, you're a fairly like quiet, smooth guy, right? So then I explain about fight, flight, and freeze, and you corner a mammal, it's going to go into some varying amount of all those three responses.
But Doc, I just want to be normal. I don't want to have all these parts, and I don't need to have them. I just want to be normal.
Right. Well, the thing you're missing on is you can't be, quotes, normal when you've got tons of unresolved trauma. It's like, Doc, I was in a multi-car wreck and I've got all these broken bones. I just want you to fix me so I can leave the ER normal. It's not going to happen. There's a whole recovery process. You're going to need multiple surgeries. So the goal is to, quotes, be normal. And actually, it's normal to not be normal if you've been through a bunch of trauma. So when a drunk driver hits you on the passenger side, it's not normal to have a broken leg, but it's normal in that situation. Same thing here. So the route to, quotes, normal is not getting rid of the parts. It's just like, first of all, there's no way to do that. The route to normal is getting everybody on board, thanking everybody for helping you out, holding the anger, which is just a normal mammal fight response, defense response. It's not evil, it's not bad. And if we totally got rid of that angry part, which is impossible, we'd get rid of your fight response. And then when you're like in a dicey situation, you need a little aggression and counterattack, you won't be able to do that. You'll be more vulnerable, more easy to exploit. You'll be less assertive. People will be able to walk all over you. So, I mean, and then the basic explanation is if you don't like this kind of therapy, you better go somewhere else.
Now, would it be fair to say that if somehow, you know, trauma treatment, let's say like EMDR or something like that would be incorporated, and the trauma or traumas, complex trauma is mostly resolved, etc., that the parts should dissipate on their own?
A little to some degree, yeah.
Because I don't need those parts anymore. I can access my regular anger or typical standard normal coping mechanisms that I would have if I hadn't had the trauma. I mean, we all have anger. We all have defense mechanisms that protect us.
Right. So I'm going to ask Moshe, the patient, okay, why are you here? What is it that's not going right in your life? And the person doesn't come for treatment unless there's sexual acting out for which they amnesia, they're cutting on themselves, going into violent rages and throwing stuff around the house and scaring the heck out of their loved ones. They're coming to and they've bought like $2,000 worth of stuff that's in their closet. They don't remember, they don't need it. They've bought all these 16-year-old girl outfits that they can't possibly fit into because they're a 45-year-old female.
Mhm.
So there's a whole bunch of trouble going on. It's just obviously not the case that everything's fine. Because if everything was fine, they wouldn't show up.
Mhm.
So then it's okay. Tell me what's not working. And you can't just wish this stuff away.
But I'm asking you, I guess, out of role, would that be the case that if a good trauma treatment helped to resolve the trauma, that the unnecessary parts should now dissipate? Would that be the case?
Well, I'm going to say that calling them unnecessary parts is host resistance.
Well, now they're unnecessary because
Right.
the trauma is resolved. So we don't need those parts to protect us anymore.
Right. That's fine. That's completely rational. That makes sense from your point of view.
Mhm.
From their point of view, all they're hearing is, you're unnecessary and I'm going to get rid of you. You're just a nuisance. Go away. It's not going to work. Then I explained that the job of the host personality is to have host resistance.
Mhm.
So if that stuff's buried inside, you don't feel it, you're not overwhelmed, you can function. If it was all just neatly tucked away forever, you would never have come here. It's not neatly tucked away forever. There's all this trouble and amnesia and voices and suicidal ideation. And
Yeah. Okay. I guess my question is more if we resolve the traumatic incidents through
Right.
trauma treatment. Again, we're using EMDR as the example.
so the answer is, we don't know.
We don't know.
We don't have,
They might still need to hold on to those personality. In other words, once those alters were created, they may still be around and dormant in the event that another trauma should happen, and they will need them to be protective of that. Is that what you
that's one scenario.
Okay.
But basically, we just don't have the research, right? We don't have, I wrote a paper a long time ago, a proposed trial of trauma model therapy and dialectical behavior therapy.
Mhm.
And the idea is, okay, we're going to have, which nobody ever does because university people are not studying DID enough. But in principle, we have whatever large grant, we have a large sample of people with DID who don't meet criteria for BPD, borderline personality, a bunch of people with borderline personality who don't have DID, and a bunch of people who have both. And then, so that's 3 groups. We randomize each of those groups to dialectical behavior therapy or DID style therapy. And we see, how does everybody do? There's probably going to be some people who do pretty well without direct work with the parts at all, or any kind of DID or internal family systems work. And then there's going to be a bunch of people who don't and need that. But what the percentages are empirically, we just don't know.
Okay. Aaron, go ahead.
Hi, Dr. Ross.
Hi.
When do we know that we need to work on parts? How could we know if this client we need to work on parts, or we could just treat him as a whole person without going into his parts?
Well, again, good answer, good question. We don't have a definitive answer because we don't have the research, right? But there's people who work with DID, make the diagnosis of DID, and they very much believe you don't have to interact directly with the parts. You get the host personality to interact with the parts. So it's a question of how much does the therapist have to be directly involved in that process. And I think some, just from a modeling point of view, you're modeling, okay, it's possible to talk to your part answered inside your head. You told me what the answer is. Well, so therefore it's possible for me to step out of the loop and you talk to your parts. And then we're back to the question of how much resolution can you get with everybody not talking to the parts. So basically you want to talk to the parts if there's a whole bunch of trouble involving the parts. If there isn't, maybe you don't need to.
Can I ask about that case that they have? I have a client that he's now about 25 years old, and he started taking Adderall as a child.
Mhm.
and he got very, very anxious. And psychiatrist said it doesn't make sense that the adults make him anxious, just continue taking it. And eventually,
It can't be happening because it doesn't make sense to the psychiatrist, right?
so eventually he started hallucinating.
Right.
And he's afraid that he's going to become a Down syndrome. And
Down syndrome,
Down syndrome, yes.
which he doesn't have it though, right?
No. And he's afraid he's complaining that his parents are not his real parents.
Oh, okay.
He's afraid to fall asleep. Sorry?
Getting pretty psychotic.
So is this DID? Is this schizophrenia? Is this because
Well,
he was diagnosed with schizophrenia, but my question is,
Oh, so why is he on Adderall for ADHD?
oh, he started on Adderall as a child, became more and more anxious.
Okay, gotcha. So, but he had an ADHD diagnosis as a kid.
Yes.
So then the questions are, is this a amphetamine psychosis? He needs to stop the Adderall and see what happens. Because you don't give Ritalin or whatever to people with schizophrenia, right? It's known to make it worse.
So could Adderall create schizophrenia or DID?
I don't think it could create DID.
How about schizophrenia?
Whether it could, well, if anybody takes enough stimulants, they can get psychotic, right?
For life? For life?
Just from the medication. I mean, it's just complication, side effect of medications. Just like you can get manic on cocaine or whatever. So it could be, 90% an amphetamine toxic reaction in a person who's vulnerable to that kind of reaction. It could be somebody who has predisposition to psychosis, where the Adderall's contributed to making it worse. I don't see DID in the mix there, because DID doesn't involve, formal thought disorder, bizarre delusions.
Mhm. So how would you treat it if he comes to you? You would send him away, or is there any model you recommend?
Well, that's always a good solution. Send them away. So, well, first of all, I'd take a good history, try and see if I could in any way figure out what I think is going on here, because I have to have some sort of hypothesis, right? And then I definitely would consider, like, why do you want to keep somebody who's forwardly psychotic on Adderall? Because even if they do have ADHD, that's the least of their problems right now. So it's not going to hurt if you lose the ADHD benefit of the Adderall in order to test the theory that the Adderall is causing a lot of psychosis. That's a very sensible thing to do. And then depending on, so you'd have to tape them and you have to wait for a few weeks and see, do they come down at all? Does the psychosis improve? If it does, good. If it doesn't, oh well, it wasn't the Adderall. Do they seem to have more ADHD off the Adderall or no different? If they don't have all of a sudden severe ADHD, I would just leave them off because that's complicating the picture. And then we're into, is this a subtype of psychosis where the person can engage in psychotherapy or not? Which, first of all, they have to be interested in therapy. They have to make a commitment to it. They have to have a work ethic. They can't be like homeless, disorganized all over the place. And if they consent to a trial of psychotherapy, then what's that going to look like? Is going to be cognitive therapy for psychosis? Is it going to be a DID-like therapy, seeing if the person has voices, if the voices can be engaged? Because I think talking to the voices is a transdiagnostic therapy technique. It's not only DID. So sometimes with people with psychosis, they don't have DID, but they have voices, and the voices are saying, kill you, or do this, or do that. It's possible to maybe negotiate with those voices some, reframe them, change the interaction between the person and the voices, which is all in the standard cognitive therapy of psychosis literature.
Dr. Ross, what are some of the best movies that were put out on multiple personality disorder?
The Three Faces of Eve is pretty good.
Three Faces of Eve.
Sybil, I don't know,
Sybil, of course.
Sybil, it's too floridly histrionic and over the top.
You don't think it's an accurate representation? Is that what you mean?
It's an accurate representation of a subgroup of people with DID who present floridly with extremely different, clearly defined alter personalities, a lot of histrionic behavior and so on. But if it was so screamingly obvious all the time, it'd be getting diagnosed all the time, right?
Right. That was your argument in the beginning. Okay, let's take a question from Moshe. I think Moshe missed most of the session tonight, but he's got a lot to say on this. Go ahead.
First of all, Dr. Ross, I listened to around 4 hours of your videos on YouTube.
Oh, good.
I read around 10 hours of this over the weekend.
Good.
I read Twombly, I read Gonzalez Mascara, I've read
Right.
Ego State Intervention. So I've done a lot of work, and I'm working currently
Most of
the
this, Dr. Ross wrote 36 books. So
Yes, yes.
You got a few to go, yeah.
I have the trauma model book. It's on my table. It's on my dining room table right now. And I didn't even know until this morning, Dr. Ross, that you were coming in. And when I saw it in the chat, I was like, I literally brought this with me to work today because there was something instructive for a case that I saw today for 2 hours. And that was with regard to pacing. In the very back of the book, you talk about leaving the trauma work for the very end, not to rush into the trauma work. And that's something that I mistakenly entered into too early,
Right.
and there were severe reactions. So I wish I had read this when I started the case. But what I wanted to ask you specifically is this client comes in with a doll, like a doll, like a toy doll, representation of her 5-year-old part. And there are times that she asks me to hold the doll, and sometimes she even asks me to take the doll home with me.
Mm.
And then I had the doll with me over Hanukkah, and then she came back after Hanukkah and said, I really enjoyed being with you over Hanukkah. Now, your recommendation about that?
Well, that's not a criminal action by you, but I don't think it's well advised. So, because it's a boundary issue, even though it's not a boundary issue because it's just a doll. What's the big deal, right? But it's the meaning and the psychology of the doll, because she feels like a part of herself was with you in the intervening time period.
Right.
So that's creating dependency, and she's thinking you as a friend and a companion, and she's actually living with you, and she's part of your personal world,
Right.
Which is not good because that can lead down a road you don't want to go down. But it's also sort of implicitly delivering the message that she can't soothe herself. She has to be at your house being soothed by you.
Right.
By you.
So, yeah, so we did do some work on the conference room of resources and different things, and she has different characters in her life, whether it's Jesus or other characters in her life who she turns to, but she seems to have this insatiable need for acceptance. And just before she came to me, she had a long list of therapists who said, I'm sorry, I'm not equipped to work with you. And of course, she interpreted it as yet another rejection. Her father left her life early at age 13. Her mother literally tried murdering her, or at least it appeared as such. And yeah, and then she was in many, many therapies after that, borderline, DID, and she managed to suppress the DID symptoms for 17 years, but they recently, in the past couple of years, resurfaced in a significant way. And now she's recognizing that this dependency, not just on me, but on others who she sees as these safe, protective figures, is complicating things. And every time I mention this word dependency or over dependency, she recoils as if like there's another reason to punish that 5-year-old part of her. And she says, I just want to kill that part. And she, shows me pictures of a little child with a noose around the neck or slice marks. She brought the doll in once with a knife stabbed into the doll with red paint all over the doll. Yeah. And
Well, I'm sure the doll's happier at your house than getting stabbed in the neck. But well, first of all, it's a difficult, complicated case, right? With no quick, easy solution. So, and you have a treatment alliance, you haven't rejected her on the grounds that she's too much of a nuisance, too complicated, which is disguised as I'm not equipped. But the message is all, you're too complicated, you're too much of a nuisance, you're over the top. That's the message she carries away. So step number one is not delivering that message. All these non-specific parts of therapy that we talked about. But I would say my strategy with her, which may or may not work, is how did it feel being a little girl who was treated the way you were treated? Not too good, right? So I wonder how that doll, so you kind of go with the illusion that the doll is a child. How do you think the doll feels getting stabbed in the neck by its mother? You're treating the doll, so this, I call this a therapeutic guilt trip.
Yeah.
You're treating the doll the way your mother treated you.
Yeah.
You deserve to be treated that way.
I read it exactly what you said. I read it, and that's exactly what we did today.
Well,
We
good.
talked about she has a 5-year-old daughter who triggers her in the same way,
No
but she
doubt.
hasn't done anything nearly violent. But instead, she recuses herself and gets her husband to take over when she gets triggered. But
So
yeah,
then,
but
how does your daughter deserve to be treated?
that's right. Right.
Love.
That's
How
right.
many children in the world don't deserve unconditional love?
Yeah.
Okay, they all do. That includes you. Why didn't you get it? It's not your fault.
Right.
And how do you wish you had been treated? How do you want to treat your daughter? Your doll deserves to be treated the same way.
Yeah.
So
Yeah,
the-
I had her envision if her mother had given her that sort of nurturing, protective treatment, how she might have felt differently afterwards, and how her behavior might have changed as a result of that too. And,
So then, cruel as it is, I think the comment is, I'm sure the doll likes staying at my house, but really, parts of you don't really come to my house with the doll. They're not there. I don't see them. I don't talk to them. Really, the doll is the outside representation of a part of you on the inside that needs nurturing by you. It's you that the doll needs to spend the holidays with.
yeah, there was one, if I can, just one more moment. There was one intervention where I had her put the doll in front of her on the table, and I had her write a psychosocial assessment of the doll as if she's a clinician.
That's cool.
She's a nurse by profession, so I thought that would make sense.
Mhm.
And I had her do the psychosocial assessment. And as she's doing the psychosocial assessment, she, the host part, is seemingly holding her cool.
Mhm.
But she told me afterwards that the doll was just losing it emotionally inside. Seeing that I was just letting her attend to the doll or do the psychosocial, and I was just sitting off to the background.
Well, so that's good, except now you've got a sibling rivalry problem between the doll and the part on the inside.
And that sounds a lot like a lot of projection, isn't it?
Oh, tons of projection. Yeah. But the idea is not, hey, stupid, stop projecting. It's roll with it and incorporate it into therapy and turn it into the inside.
Thank you.
Okay, let's take one last question, if that's okay. Elliot Kaplan, go ahead.
Yeah, hi. Yeah, thank you, Dr. Ross.
Before we get the question,
Yeah.
I really would like to do part 2.
We're on. Let's talk offline. So
Yeah.
would I.
Because obviously we're not finished here.
We're not finished. But I don't always have the chutzpah to ask for a part 2. But if you're offering,
Well, I asked myself.
okay, you asked your part. Oh, we
Yeah.
have a resounding yes in the chat box. So
Good.
I mean, this is fascinating. This is absolutely fascinating.
I can't understand why mental health professionals don't want to get into this. It's so interesting.
But there's something scary for us. I think there's something scary for us about complex trauma and this sort of liability and responsibility that we have to our clients to not hurt them too much. And that's how I feel without being sufficiently adequately trained in it. You're laughing at me.
No, I'm laughing because I agree with you totally.
Okay, Elliot, go ahead.
Yeah,
I'm laughing along with you.
So my question is, and it kind of even dovetails a little on the last question. When do you recommend couple therapy, family therapy? When don't you recommend it? It seems to me that it's a heavy burden on the therapist to deal with such a client one-on-one. So at least my style is I would try to bring the family in when possible.
Oh, definitely. Whenever possible, the more the better. But then, of course, what if it's a battering husband? What if it's a controlling, demeaning husband? What if it's a husband who doesn't believe in DID?
Mhm.
So, or actively.
Wouldn't that give you more information about what the client is living with? Even
Yeah.
a couple session might be a
For
good.
sure. Couple of sessions is always good.
Mhm.
Right.
So wait, so help me understand this. If we have more parties in the room, so how is that going to be helpful if the treatment needs to be within the client's self and parts? Isn't that going to be a disruption?
Well, it's not every single, well, I mean, if you're going to have 150 therapy sessions, devoting one or adding on one couple session, it's not the end of the world, right?
Oh, I see what you mean. Okay, but not as the treatment for the DID.
No. No, it's like a one or two, help me out understanding
Like
what's going
psychoeducation or bring your
history taking, eyeballing the significant other so you get your own feel, and then off to couple therapy with somebody else if required.
okay.
Yeah. So that answer your question?
Yeah.
Okay.
Good.
So I guess we're gonna have to pause mid-sentence and pick up on a part two, maybe in February or March. Or we'll talk off the air, what works for you.
Okay.
But this was fascinating, and I really will encourage more people to attend after having heard this. I really appreciate that you came on tonight, that you came on so graciously, what you've shared for our community in terms of your books and articles. I would encourage everybody to just Google or Amazon, Dr. Colin Ross's books, see what you come up with. Moshe Fund had one hanging in the background. I forget which one it was. But
You have dissociative identity disorder.
but Colin, for a junior beginner, which book would you recommend as for a starter?
Trauma model therapy, number one. And that's thin book, treatment of dissociative identity disorder for getting into DID specifically.
Okay. So for those of us who want to get a little more of a taste.
And I always like to point out that really you should have 3 copies of each book, because you need one in the bedroom, one in the living room, and one at your office, right?
But Moshe said that he has his on his dining room table, which makes me wonder, is he eating it?
I hope not.
Right. And then we have other problems to deal with.
All right.
Well, thank you very, very much for coming on. Really, really greatly appreciated. Thank you, Aaron, for the recommendation. And hope to see you again soon. Good night, everybody. I'm going to stop the recording now.